An incidentally discovered adrenal mass, or adrenal incidentaloma, is a common finding on cross-sectional imaging, with a prevalence of 2 to 5% in the general population. Prevalence increases with age, from about 1% at 40 years to nearly 7% at 70 years due to widespread imaging use. Most incidentalomas are benign non-functioning adrenal adenomas, but a significant proportion may be hormonally active or malignant. About 25% of lesions are hormonally active, including cortisol-secreting, aldosterone-secreting, or catecholamine-producing tumors. The first clinical priority is always to rule out hormone excess, especially pheochromocytoma, using plasma or urinary metanephrines. Cortisol excess is assessed using a 1 mg overnight dexamethasone suppression test to detect subclinical Cushing syndrome. Aldosterone and renin testing is indicated in hypertensive or hypokalemic patients to evaluate for primary hyperaldosteronism. On imaging, unenhanced CT is the first-line study, where lesions less than 20 Hounsfield units are usually benign adenomas. Lesions greater than 20 Hounsfield units or with irregular features require further evaluation for malignancy or metastasis. Magnetic resonance imaging with chemical shift is preferred in pregnancy or children for better tissue characterization. Biopsy is rarely indicated and should be avoided in suspected pheochromocytoma or adrenocortical carcinoma due to risk of crisis or tumor spread. Management depends on hormonal activity and malignancy risk, with surgery indicated for functional tumors or suspicious imaging features. If imaging shows benign features and hormonal tests are normal, many incidentalomas require no follow-up or intervention. Adrenocortical carcinoma is a rare but aggressive cause of incidentaloma, with an incidence of 1 to 2 per million per year. Genetic alterations include TP53 mutations, WNT beta-catenin pathway activation, and IGF-2 overexpression in most cases. Imaging and pathology features such as Y score greater than or equal to 3 suggest malignancy and require urgent multidisciplinary management. Staging follows the ENSAT system from localized stage 1 disease to stage 4 metastatic spread with distant organ involvement. 5-year survival is around 30 to 40% and drops significantly in metastatic disease despite aggressive therapy. Treatment begins with complete surgical excision, often en bloc, followed by adjuvant mitotane therapy in high-risk patients. Mitotane is started at 500 mg 3 times daily and titrated up, with therapeutic levels maintained between 14 and 20 mg per liter. Advanced disease may require multimodal therapy including chemotherapy with cisplatin, etoposide, doxorubicin, and mitotane. The key clinical takeaway is that adrenal incidentalomas require systematic hormonal evaluation and imaging to rule out malignancy and functional tumors early.